Good afternoon, guys. I'm just showing a case similar to what we saw last time, which Dr. Cherniak said and showed, and she mentioned that this is out of phase, in phase. How do I remember? Everything is outlined. So O for out of phase, O for outline, and O for oil, which is fat. So it is suppressing here. So there's fat, and every structure is outlined here. And the liver is fatty. Versus if the liver is supremely fatty, so we see that the outline here is missing, and all the other structures like veins are outlined, and we do not see outline around the liver, which means liver itself is acting like a glob of fat, similar to mesenteric fat. So the interface is just fat, and there is no indwelling artifact. And I'm showing this T2 here because liver is even more hyper intense than the spleen, and that's the CT, and the patient had hyperlipidemia induced pancreatitis. So just reiteration of the fact that extreme amount of fat can make liver behave like a lobule or globular fat, and other structures in the liver like portal veins can show Indian artifact. Thank you.
That's awesome. Yashant, do you happen to know what like the maximum amount of fat is that you could get in your liver, like percentage wise?
I did not find anything, but I can double check.
Okay. Because this would suggest, like, if you're getting the dropout, I know, like, we always get the maximal amount of dropout, like the India ink, if there's 50-50 fat and water, right? So that would suggest, like, this is like 50% fat or something. But I'm just kind of curious, like, what the max is.
Sure. No, I wish we would have done elastography on him. So we would have known like at least the rough percentage, but I think I can look up literature and let you know.
Okay, thank you.
Okay, this is a patient who has carcinomatosis from a colon cancer primary, and it was a follow-up treatment response, and I was looking at this what looks like a pigtail catheter, but it was coming down the course like an enteric tube would be coming down, but it was not an enteric tube. Any thoughts, S? This was my first time seeing this, and I had no idea
like
what it was.
your gastroenterologists do a lot of interesting procedures.
Yes, they do, including this one.
Wait, where's that going?
Right? I was like, what is that?
Some cavity, some cystic lesion in the lungs?
No, I found out that this is a percutaneous transesophageal gastrostomy tube. And this is an alternative to patient was getting it for decompression because they had malignant obstruction. It's palliative. And so in patients, an NG tube can be used for both feeding and decompression. So this was serving as primarily for decompressive purposes. And so this is a PTEG, and it was developed in Japan in 1994. It's an alternative to PEG when a PEG cannot be performed due to contraindications. And it can serve both purposes for decompression or feeding. So look at this is what they do. This is the kit. They access it percutaneously into the esophagus using both fluoroscopy and ultrasound guidance. And what you end up with is what we saw on, it's actually a transesophageal. So this part of the PTEG is external to the patient.
And then maybe the distal part is looped because this is like you need to have it there for a long period of time.
For decompression.
Yeah.
And for decompression. And it has a lot of side ports for decompression. So it's, according to that paper, it's safe. It's as safe as regular PEG tubes. And it can be an alternative options for patients who cannot get PEG tubes for whatever, reasons.
Very cool. I'm now remembering that I've seen one of these, but yeah, obviously forgot it. So thank you. To go. Okay, this person had abdominal pain.
Is it gist? Is it like coming off the bowel gist?
So you're talking about this mass here, right? Yeah. So yeah, very heterogeneous mass coming off the bowel. I was showing this to my residents earlier. One of the things that, so you brought up gist, which is great. And then another thing that was brought up was lymphoma. And we talked about how lymphoma can look like anything. It's usually more homogeneous, whereas this is pretty heterogeneous. This is what it looked like on coronal. You know, is it mesenteric? Is it affiliated with bowel? It's definitely touching bowel. But for mesenteric masses, you know, it doesn't really look like a carcinoid lymph node met. It looks too big for that. Desmoid is usually either more homogeneous or more infiltrative. So anyway, and this was affiliated with the small bowel. So this was a gist. Small bowel gist is worse than gastric. So we put it into the nomogram, and it was interesting. So it said like, basically if this, so it was 10 centimeters arising from the small bowel, and then you also put in the mitotic index. If the mitotic index is low, they had about a 50% chance of recurrence at 5 years. If the mitotic index was high, they had a 99% chance of recurrence within 5 years. We now have the 5-year follow-up, and I will show it to you. And so there are liver mets. And then there's extensive peritoneal disease, kind of mimicking bowel, but you can see that like all of the fat is filled up with all of this peritoneal disease. There's even larger masses in the pelvis. So this is kind of following the typical pattern of what we expect from like an aggressive small bowel gist. Gist likes to spread hematogenously and give you peritoneal and liver metastases. Like they don't tend to go lymphatically, so like no lymph node metastases. They can also give you lung mets. So, yep, that was that.
So, elderly male with cirrhotic liver, and all the sequences are pretty impressive. So, what do you see on this sequence for liver?
I see a geographic difference in signal between right and left lobes.
Exactly.
When it's super geographic like that, I always think about a portal vein abnormality, like is one of the portal veins out? Based on this out of phase, I can't tell which one is hypervascular, but in general, okay, now I definitely see like a signal abnormality between the two, but I still want to go to my vascular phases. Oh, okay. Wow. So now it's clear that there's like a heterogeneous infiltrative process involving the entire right lobe and probably the right portal vein. Yeah,
Correct.
like large, like there's tumor thrombus. Yep. And that's what's causing the perfusional abnormality, but also just like, yeah, massive infiltrative process. So given all those findings, I would say HCC. And that's, yeah, on the diffusion, you can see like really nice infiltrative restricted diffusion and tumor thrombus.
Absolutely.
This ADC is not very impressive, but
not very impressive. Cool. Yeah. Like if there was no tumor thrombosis, even then I expect the signal would have been different because this was all infiltrative. At least on DWI or T2, we would have seen like, stark difference in the left and the right lobe.
Yeah. Do you have the arterial phase?
I do.
Okay. So it is kind of enhancing and washing out. So we could say that this is HCC. Sometimes when it's infiltrative and there's so much portal vein tumor thrombus, it like doesn't become arterial enhancing because the artery is trying to like save that lobe. And so like it technically doesn't meet criteria, although like it's definitely, like the TIV basically makes it HCC. But yeah, sometimes in those cases we're like, okay, correlate with AFP, and then we'll feel like more certain.
Sure.
Yeah.
Cool.
So this was a case of a renal mass. You can see it here on T2. Here it is on the arterial phase.
Okay.
You can see that's definite enhancement on the subtraction images. Here's the venous. Here's the delay. Okay, and it did not have microscopic fat. It did not have macroscopic fat. So we basically said this was an RCC, and that's what this was. But the point of this case is to kind of discuss like the renal nephrotomy score. So you can see that the renal nephrotomy score is basically like saying how easy it's going to be to do a partial nephrectomy versus a total. If it's more exophytic, smaller lesion hanging off one of the poles, then that's much easier to do like a partial nephrectomy on. And like laparoscopic. If it's here, this is like in the interpolar kidney and it's getting very close to the collecting system. This makes it more challenging to do a partial nephrectomy.
Okay.
So, and then the size, if the larger it is, the harder it is to do a partial nephrectomy. So anyway, they came post nephrectomy. Here they've got, they've done the nephrectomy, partial nephrectomy, and there's some fluid around it. It's kind of within normal limits. And there's a drain here. So one of the teaching points is like, anytime you're assessing fluid in a postoperative bed, you have to also assess you have to know clinically how much is coming out of the drain. So even though I thought like this amount of fluid is kind of normal, like not unexpected, maybe just some blood products, the urologists were like, actually, there's a lot pouring out of this drain and the creatinine is elevated from the drain fluid. So we had like a high suspicion that like maybe there's a urine leak. Luckily, we protocoled this as a urogram, so we do have a delayed phase. And then here is the delayed phase where we can see that on the excretory phase, the excretion from this calyx is going directly like out of the partial nephrectomy site into the perinephric space. So there's a definite leak. So I don't know, it's just a cute little example. They put a stent in, like a nephroureteral stent to kind of pull the urine down the path of least resistance, and they're going to see if this kind of dries up on its own. Anyway, this is one of the hazards of doing a partial nephrectomy so close to the collecting system, to the calyx. They try to oversew the calyx, but it often is a very delicate structure and that doesn't always work. And so testing for the creatinine from the fluid is helpful, and then doing this delayed scan. And I was also telling my residents, just for like the students out there, even if you didn't protocol this as a urogram, if you're ever worried about a urine leak, you can always like bring the patient back later that day or like an hour later, including in trauma scans, because since the contrast is going to be excreting for like up to 12 to 18 hours afterwards, you can see that leak even on a delayed scan. So I've done that before where it's like a portal venous phase, and then I bring them back for a delayed, and then we can see the leak.
Nice.
Yeah.
Yeah. What you said, like, definitely now makes so much sense in my head, and that just reminds me. I think 2 or 3 years back there was this SAR consensus reporting template for renal masses, and they do definitely talk about the fact that you have to say like definitely like upper pole, interpolar, or lower pole. Also have to say, is it anterior or posterior, and how do we determine anterior is you just like imagine an imaginary line from the hilum outwards, and then anterior versus posterior, and like how much exophytic, like fully exophytic or partly exophytic. So yeah, those things definitely make much more sense in my head now.
Yeah. So I don't give a nephrotomy score, but I always basically describe exactly that within like all of those factors, and like how close is it to the collecting system, how endo versus exophytic, like you said, interpolar, anterior, posterior, and then hanging off the poles. So, yeah, this is a example of that. Okay.
So That's the paper I was talking about for renal masses. This is lexicon from Society of Abdominal Radiology, published in 2021. And they do have a table where they talk about all the descriptors for renal masses. So they talk about, like, its composition, how does it look like, solid, cystic, size, is laterality, margin, is it well-defined or ill-defined, talking about growth patterns like endophytic, less than 50% exophytic, more than 50% exophytic, is it anterior versus posterior according to this imaginary line, craniocaudal location, presence of necrosis or heterogeneity or homogeneity, and a couple of other descriptors.
I love these SAR consensus, like about definitions, because like, for example, even Bosniak, like the first time they released it, there weren't like strict definitions. So then when you do research, like people are categorizing things in different ways, right? So it's really good to come to like a consensus about like, how do we even use these words that we're using to describe these lesions so that we can all like be talking about the same thing, describe it the same way, and then even do research, that is more concordant.
Yeah, the DFPs are fantastic. I mean, and the templates, they give out all the protocols and techniques and the reporting templates. It's fantastic.
Yeah. Okay, awesome. We will read this paper. Thank you, Yashant.
Sure.
And this is a patient who had a prostatectomy for prostate cancer, and there's like a just evaluation, just assessment of recurrence. And I came down and I saw these two little hyperdense, and they look like bulking agents. I'm like, but
Yeah, and
it's
wait,
not.
in one image, it's like a smiley face.
Right. Smiley face. Where's the
Right
smiley
there.
face?
Down
What?
one.
Where's the smiley face? Oh, there it
Yeah,
is. Elmo. I see Elmo.
and that's exactly what I see. But I actually I have so much Elmo going on in my house that I didn't know if I was too biased. But yes, I see Elmo.
This is an Elmo sign. Uh, so I was like, what is that? And then there are these radio opaque kind of lines. And then it goes to what looks like
Wait,
an
that's the Cunningham
external.
clamp on the
Oh,
penis, right?
yes, there's your clamp. And I'm
That
glad you
Yashant
mentioned the name because I didn't
taught
know
us
the
about.
name. And then the urethra is also distended. So let me just show you the sagittal. I'm like, what is that? It doesn't look, normal artificial urinary sphincter is kind of more around the urethra, and then they have kind of the inflator device in the scrotum with a reservoir usually in the retropubic space. And this is not those findings. So any guesses as to what this is?
I've never seen it before, but is it some kind of new prosthesis?
Yeah,
Like,
so the patient, go ahead.
you want to fill that space so that it does not get either hernia or infection, or just bulking agents?
Well, so the patient did have an AUS, artificial urinary sphincter, before that got infected. So you can see all of the inflammatory changes here. And so the patient had that removed and then got this place. And this is, let me drag over the screen that describes what this thing is. This is called a ProACT. ProACT. And it's basically like a bulking agent for men who have failed artificial urinary sphincters. So that's exactly what they do. They go to the bladder neck. Here's a urethral anastomosis. And then they put these two little balloons that they inflate. And then the filling ports is here. They don't actually manually fill it like they do for urinary artery sphincter, but it can be adjusted by the urologist to whatever they need to adjust it to, kind of like a gastric band. And then that's it, and it serves functionally as a bulking agent. So that's what this is.
Very
That's super cool. It looks exactly like your imaging findings.
Yes. Elmo sign.
Yeah, and they must have decided to make it radiodense, like maybe to help with CT or.
Yes. Yeah, probably most likely, yes.
yeah, similar to how we how they've made hydrogel also hyperdense now.
Yep.
Yes.
Awesome. Okay, so this is high resolution T2 of the pelvis. Patient has multiple fibroids, you can see here. And they have this ovarian lesion over here. You can see they've got other follicles in the ovary, and then they have this lesion right there. I'll show you on, this is what it looked like on post contrast and even on subtractions.
Is it like something like what Dr. Tan showed last time, like papillary fronts, serous cystadenoma, papillary borderline?
Okay, hold on. And then this is the diffusion. So it's like bright and dark. Okay. So I thought this was confusing because the enhancing components are very T2 dark, right? Does that ring any bells for you guys?
Some fibrotic.
Yes. Right. This looks very, very T2 dark. If the whole thing had been T2 dark like this, we would have said like fibroma, right?
Yeah.
So what do you call it when there's like a cystic part and a very T2 dark part?
Did you just say it's like a cystadenophybroma?
Yeah, I don't know if I don't think he said that, but anyway, yes, that's exactly what this was.
There's
So,
3 types.
I want you to tell us about that, but I do want to point out one thing. So anyway, we immediately I was like, okay, this could be a cystadenophybroma, but because like it wasn't dark on DWI, I had to kind of like hedge towards like, well, I don't know, like can't exclude something more. I said benign or malignant, possibly cystadenophybroma, and it was resected, and that's what it was. One interesting thing is that it was there. This is 10 years prior. And there it is. So it had grown as well, although any kind of benign lesion can grow in 10 years. So anyway, it's just kind of a cute little like thing, kind of debating. Like I really strongly felt like it's going to be a cystadenophybroma. That's a benign ovarian lesion that's like a mimicker of malignancy. But because it had grown, because like it was enhancing, we just kind of gave the differential and it was resected and it was a cystadenophybroma. Nelly, can you remind us of the 3 types?
Yeah, I'm trying to pull it up right now. There's lesions that are more cystic, lesions that are more solid, and then something in between.
Okay, but they're all like considered benign, right? They're not, it's not like when you say 3 types.
Correct.
Okay.
Yes, no, it's just an imaging pattern. There's like 3 patterns of imaging characteristics on MR.
Okay.
So this is from the Korean Journal of Radiology, and I don't know if there's an established classification, but this journal reported 3 types that I'm aware of. So here are some of the imaging characteristics, and so type 1 is a multilocular solid lesion. So here's an example of a type 1 that they provided. So it's solid, there's cystic components, multicystic and solid. Type 2 is a bilocular or a unilocular, maybe more like what your case, Aarti.
Yeah.
So here are 2 different types of type 2. You have a unilocular cyst with little areas of solid components that are dark, T2 dark. These are 2 separate cases according to the paper. And then type 3 is purely cystic mass resembling a serous tumor. So here's an example of a type 3. So cyst, multicyst. This looks multicystic, but I guess just purely cystic without any solid component.
I think, and I remember you showing this before and us being like, well, if we had that, there's no way we would even bring up like cystadenophybroma. You know what I mean? Like you'd have to just bring up like possibly a epithelial neoplasm.
Right. Yes. Yes. So those are the three types, but I don't know that this is an established classification. Maybe, maybe this is just something that this paper described.
Yeah. I do want to show one more thing about my case though, which is the thing that we found confusing is that even in that paper you just showed, there's this thing called like dark. And that's the thing you see on like fibromas too, where it's dark on DWI and ADC. And in ours, the enhancing component was like bright and then dark. So it didn't have that like dark thing. So we kind of were like, oh, like, I don't know, could it be some variant of like a malignant thing? So anyway, it didn't follow that exact rule. But overall, very fibrous, very T2 dark, and then very cystic. Always think like, think about a cystadenofibroma.
So this is an example of another case of a cystadenofibroma, companion case to Aarti's. This is from Mark Sugi's case collection. And you can see here you have a cystic component and solid. So I guess this would be what, type 1 if we use that Korean journal classification maybe. There's solid components to it, so it's not type 3. And there's, so anyways, there's the dark and then the cystic components here. And then the second companion case, this is another case from his case collection. So it's a CT and ultrasound variants or versions of it. So here you have the multicystic with solid components. And then this is the ultrasound correlate to the same case where you see solid components and then cystic components in the pathologically proven cystadenofibroma.
In the CT scan, the lesion is the thing behind the uterus, right? Isn't that
Yeah,
bowel in front of it?
I think it's this thing here.
Yeah,
And
okay.
it might be tethered. I'm sorry, I only have a single image, so I can't tell you if this, yeah, maybe it's bowel. So I don't know if it's part of it or if it's just a budding up a loop of bowel that we're only partially seeing.
But even that thing in the back is a gorgeous example of like really cystic and solid, like you could even imagine that this really could be a cystadenofibroma. I think that MR would be like the next like awesome best,
I agree.
Yeah.
I think you definitely need an MR for diagnostic because you need that T2 signal.
And if we bring it up, they can actually do fertility sparing partial oophorectomy and get it frozen on it. And if it's cystadenofibroma, then they can like actually do fertility sparing. So it is important to bring it up.
That makes sense. But not a common, it's not something common that we see. And it's not definitely something that residents like learn, right? This is not part of the typical bread and butter abdominal radiology. Like
I agree, but actually I don't think it's super uncommon. So that's literally why I wanted to show this case. Cause like when we saw it, we're like, wait, this is reminding us of like the cyst and like the super dark fibrotic. Like this is the exact case where we can bring it up,
And I think MR is diagnostic for it.
Yeah.
So I think it needs to be added to the common kind of teachings and learnings that the residents have.
Exactly. Yep.
I have a comment. So if MR is there, yes, it is going to be T2 dark, and we might lean towards cystadenofibroma, the T2 dark fibrous component. Say if it is just ultrasound or CT, I'm just thinking of the case that Dr. Sekhar showed last time, solid cystic estrogen producing granular cell tumor. So just from my understanding and just from my own list of differentials, so if I see solid cystic masses on CT or ultrasound, I would think of these two. Is that right?
Yes. And then that's where I think the MR can be really helpful.
Okay.
And actually in that paper, even it showed, it said like the dark on DWI is more confirmatory, and then the type 1 enhancement curve. So if people are doing, because it's like a low level progressive enhancement because it's so fibrotic. So if they are doing the enhancement curves, that can also be helpful.
Okay, thank you. And that dark signal is important because that distinguishes it from like a malignancy, like a mucinous adenocarcinoma.
Yep.
Which are typically more hyper intense on T2.
Yes. So companion case to ProACT, and this is from Radiopedia. So they are showing a case of a 65-year-old male, and the ProACT, the hyperdense or hyperretenating should be symmetric around the urinary bladder, and it is displaced here.
Yeah, this definitely doesn't look like the picture or Nelly's case where like they were side by side.
And the balloon looks really quite inflated.
Yeah. And we see those segments in the testes as well, scrotum as well.
Awesome. Okay. Not an eye test. We see fibroid uterus and this cystic lesion.
It looks like there's a claw sign from the psoas. Makes me almost think about a primary psoas process.
Okay. Like what? I have an MR if you want it.
Yeah, I'll take an
kidney's
MR.
missing.
Kidney's not missing. Kidney is fine. Oh, wait, hold on.
Oh, wow.
Left kidney.
Yeah, there was a partial
Myxoid.
nephrectomy before. It's unrelated.
Okay.
Myxoid.
Okay.
Myxoid lesion.
Okay,
Needs
this
to
was
come
the
out.
T2. This is the delayed. This is the subs. Not a lot of adjustment.
Schwannoma?
Cystic schwannoma is a great thought. So yeah, we were like, this is a retroperitoneal cystic lesion. We were asked like, is it a lymphangioma? Does not really look like a lymphangioma, not blobby. It has these septations. It also has this claw sign with the psoas muscle. And then we were thinking like, oh, could it be like a retroperitoneal mucinous lesion? But I think Nelly hit the nail on the head in the beginning when she said like claw sign with the psoas. Therefore, like, is it truly like actually a muscular based lesion? So the surgeon actually brought up like, could this be like an intramuscular myxoma? And that's what it was. So
wow.
like, don't forget about our MSK lesions. If it seems like it's arising from the muscle and you're not sure about the differential, like consult your MSK colleagues. But yeah, it was an intramuscular myxoma, which tend to be really T2 bright. Yeah, so it kind of faked us out a little bit for a while, but then eventually we're like, oh yeah, that claw sign is key.
So this is case which was donated to me by Dr. Dogra. So this is a young male who comes with minor trauma to the scrotum. And what do we see?
Is this next to the testis? It looks like a foreign
What is
body.
that linear? Like
Yeah.
there's two curvilinear, like echogenic. It's like iatrogenic. Is that, yeah? Is it something?
Yes. Say if it was in the breast, what would you think of?
Like a caps, like silicone capsule.
Yeah, ruptured implant, ruptured breast implant. So it
Oh,
is.
is this a ruptured testicle?
Yes, ruptured testicular implant.
Yeah, wow.
So like what we call as linguini sign. So that's what it is on ultrasound in testes, and just showing you how normal prosthesis looks like. So these are two different patients. So on the right, we have like normal testes and the implant, which is like full with saline, and we see the reverberation artifact. On the left is the donated case, and it ruptured. So it looks like, you know, the wavy noodles or the linguini sign. And the implants that's the ultrasound appearance. How it looks on CT is, it's just a bigger version of how the ProACT looked like. And now, after I think 1990 or something, they're filled with saline. Back in the day, they were filled with silicone, but now this is obsolete. And sometimes they can be complicated with hematoma formation. That's about it.
What was the reason they switched over to saline?
Because this, I think silicone causes some fibro-inflammatory process. One, if it ruptures and if it leaks out. Can't remember the exact reason, but one on these lines only. If
Yeah, I think silicone is much more toxic.
And interestingly, the outer covering is still silicone. It's just the silicone gel which was inside. So that formulation was toxic, giving rise to production of inflammation, like supreme amount of inflammation. So that's why probably it was switched. And just to give perspective, that's how the implant looks like, different sizes.
Interesting. Also interesting that they're different sizes. You can try to match it, I guess, to the other testicle.
Yeah.
Okay. So
Adrenal lesion.
good thought. I'm just gonna scroll all the way through.
Yeah, I don't know. Do you have the coronal?
I do, yes.
And there's thrombus in the IVC, tumor thrombus.
Yeah, so we have a mass, we have heterogeneous soft tissue, we have it invading the IVC. It's actually growing up all the way up to the heart, right there. There's some bland thrombus in the hepatic vein, and then there's bland thrombus below this level, kind of going into the renal vein also. I'll show you the coronal. Sorry, hold on, I'm not sure which study I'm actually even showing right now. But anyway, it's so the question you guys were asking or thinking about was like, is it renal or adrenal?
Adrenal.
So we have one vote for adrenal.
Kidney seems like.
Yeah, it's adrenal.
Yeah, exactly. So even it's maybe even
Adrenal.
invading the kidney here, it's
Yep.
pushing it, and it's not the law sign.
Yep.
So this was adrenal. So what do you guys think it is?
ACC.
ACC,
Yeah, exactly. So this was adrenal cortical carcinoma growing up the IVC to the heart. There was actually already lung mets. And then another kind of interesting part of this case.
So are those all just ovarian metastases bilaterally?
Oh, no, these are actually, that's what I wanted to show you. These are actually necrotic fibroids, but the cool thing is it's actually a bicornuate uterus.
Oh.
And I'll show you the MR where you can see the two endometrial cavities separately. So just incidentally had a uterine anomaly.
Oh my gosh.
And
Wow.
actually, Nelly, back to your kidney observation, yes, the left kidney was absent because of this uterine anomaly. So look at this. Basically, we see two uterine horns with two endometrium and big fibroids in each of the horns.
The fibroids have a funny appearance. They have these T2 cystic foci. It
I
almost looked like
know,
adenomyoma.
we contemplated that, but they were so dark that we decided that they were fibroids. But yes, I agree. And then the thing that like there's like a huge cleft between the two, so we it definitely felt like a bicornuate. So that was just incidental, but yes, yeah, that was it.
I found why we don't use silicone. Can I share that?
Sure.
So silicone is not used because of risk of development of connective tissue or autoimmune diseases.
Yeah, autoimmune. I remember this now.
Mm.
Yeah.